let's move on. And I'm really delighted that we are having, questions, and this is useful for, participants who are joining us. So thank you. I'm now going to introduce Dr. Max Liebau, who is a colleague, a consultant, a pediatric nephrologist from Cologne, and Cologne, who is really been a sort of, leading the charge, I would say, from pediatrics for autosomal recessive PKD, and is chief investigator for a number of studies, but I think the one which really stands out for me is this international registry for polycystic kidney disease, for this rare condition, which has, individually we see very few. And when I've sort of heard Max talk before, it's been really stimulating to see the amount of new knowledge he has put together for us, really trying to have a deeper understanding, so that both clinically and from a biochemical but also research perspective, we understand the medical condition for these children, because as new therapies come along, as was being discussed earlier, these children would be able to have access to those. So Max, you've got a title, I think, which is What's New in ARPKD, and delighted to have you here virtually, and thank you.
Right. Thank you very much. Thank you for inviting me. And I really am. I'm looking forward that maybe in the future there will be face-to-face meetings again. I do remember being in Birmingham. I do remember being in London. It was great fun. And thanks for having me. So yeah, the title of the talk is What's New in ARPKD, and this is just a conflict of interest statement. I'm briefly going to comment on one of the VAPTANs in the talk. So very briefly, I mean, we've heard the introduction by Larissa, who really showed us all the clinical aspects of ARPKD and ADPKD. Just very briefly, we're talking about ARPKD, and these are just pictures of the typical presentation. I mean, all of you are experts in the field, but just to compare it to ADPKD with the discussion we just had, in ARPKD, we have all these little tiny dilatations in the kidney, that you can also see here on the ultrasound. There are some real cysts developing, but it's all this grisly appearance of all these tubular dilatation microcysts here seen on the MRI picture, whereas in AD or PKD, autosomal dominant polycystic kidney disease, you have these larger cysts, these white spots here on the MRI in the kidney, in both kidneys, or here in the ultrasound, or here on this pathological sample. We've just discussed a bit about the genetics behind it, and classically this is caused by variants in a gene called PKHD1, and ADPKD is caused by variants in two genes called PKD1 and PKD2. As Larissa has pointed out, we are learning an awful lot over the last few years with the new field, or the new possibilities of genomics, and there are these few cases where there is an overlap between ARPKD and ADPKD, both clinically and also genetically. So it may be some sort of as we now say, a spectrum of diseases, with ARPKD and ADPKD being at the ends of this spectrum. So how does ARPKD develop? Just very briefly, every kidney consists of about 1 million mini kidneys, if you will, and you've heard that in the cortex, this blood is being filtered, and then so here in this what we call glomerulus, and then this filtrated blood, the primary urine is then worked on in these tubules, and salt is taken back and water is taken back, etc. And then in this this part here at the very end, this is where in ARPKD the cysts start to develop. You've seen the drawing about the tube that doesn't develop well in ARPKD, and this is what it looks like in histology. How and why do these cysts develop? And again, we've heard about the genetic. It's actually almost the same picture that you've seen in the previous talk. And I've taken this from the PKD Charity UK webpage. It's variants in this gene that is called PKHD1, mainly in this gene. And only if you have two affected copies of that gene, then you will develop the disease, and you inherit a copy each from mom and dad. And only if the affected variants come together, then ARPKD will fully develop. So this is a very complicated slide, and no worries, we're not going to go through all the details of the slide. But what it is meant to show you is that in polycystic kidney disease, and this is both true for ARPKD and ADPKD, there are changes within kidney cells. So this drawing is meant to represent a kidney cell, and you've heard about the primary cilium in the previous talk. So this is a sort of little extension of the cell surface, and the gene products affected in polycystic kidney disease are partly localizing to this part of kidney cells. And the job they are doing up here is that they are regulating the way signals are delivered from the external to the internal part of the kidney cells. And this is obviously a highly complex process. And what this slide is meant to show you that all these little green parts here are parts where we might be able to interfere pharmacologically at some point. Either there are trials going on already, especially in ADPKD, as we're going to see, or there might be some trials in the future. So it is a very complex situation, but there's also hope for us learning from this, from the basic science work, and trying to understand these events in kidney cells to then be able to tackle it in the future with targeted therapies. Obviously, this kind of research takes years and years to fully understand such a complex network. This is just one example how we can then see changes in one of these signaling cascades. On the upper part, this is a normal kidney, and here you don't need to think about the details. We're just looking at one marker of how quickly cells sort of replicate and grow, and down here, this is from an ARPKD kidney. You see that the signal here, these brown little dots, are much more pronounced than up in the healthy control. So we have more activation of this specific signaling, or the signal in these kidney cells. So these are just little steps ahead to try to understand the signaling network in kidney cells. Clinically, obviously, there are everyday questions that are being asked in ARPKD, and we've already discussed a bit about the blood pressure issue. That is a very huge problem in daily clinical work. But today I want to focus on maybe mainly two aspects. How is kidney disease going to develop is a huge question. Are there any risk markers that we could identify that could help us to identify children at increased risk of kidney disease progression? We're later going to hear about the liver disease, so I'm not really commenting on this very much. And then, how about adults? This is a newly developing field. So obviously our goal is, as it was pointed out, is that we want to do individualized, sorry for the typo, personalized medicine for the patients, but it is highly specialized medicine of a rare disorder. So there are some recommendations. Larissa already mentioned that that workshop that we had in 2013 in the US with experts from around the world, specifically working on these recommendations for ARPKD. More recently, there was this general recommendation for cystic kidney diseases early in childhood, and what these manuscripts summarize are recommendations on genetic testing, antenatal assessment, treatment after birth, etc., and they can give a rough guidance for physicians treating ARPKD patients. Still, then some years ago, we thought, okay, we've learned a lot about ARPKD and other polycystic kidney diseases, but still, we need to understand the specific cause of ARPKD much more in detail. So we set up this registry study that was supported by various societies: the German Pediatric Nephrology Association, the German Society for Nephrology, the European Society for Pediatric Nephrology, etc. And we said we want to collect data from across Europe with the goal to describe the natural disease causes in a first step, and then potentially as a second step, identify risk patterns and risk markers in patients. Also as a potential readout for clinical trials, because as you've heard, there are no clinical trials for ARPKD out there yet. And this was in close collaboration with Lisa Gay Woodford from the US and Larissa. And I really want to point out that it's very, very important that we run these registries. And if you have a chance to join Rare Renal in the UK, then please ask your doctors to do so, because it's really a way how we can learn and improve in the future. And also these different registries are sort of comparable to each other. So there is really a way that we can learn from each other. In ARPKD, what are we doing? We're collecting sort of basic data set, and then we try to follow these patients about once a year, asking for ultrasound findings, kidney function findings, etc. We have also started to storage biomaterial. We look at the genetic information where available, and also for patients who are being recruited, for example, as adolescents, there's also a chance to enter data retrospectively, as in the case where a patient is diagnosed in the with 16 years of age, was considered to be ADPKD, then he or she will also be able to join. We have by now 130 centers from 30 countries joining, and it is supported also by PKD International, the German Federal Ministry for Education and Research, etc. So by now we have 680, I think it's 689 by now, patients included, with almost 3,800 independent visits. And one thing that is good is that we, and this was when we had 600 patients included, this figure, is that we're having more and more patients for whom we really have data on the cause of the disease. So one thing would be to have data at one point during the disease, and this is also very important, and you can learn something, but it's also very, very helpful to be able to follow individual patients throughout their disease. And here we have, by now we have more than 100 patients with 10 visits. So that may in the future be helpful for us to understand, if a patient has a certain symptoms early in life, he or she may be doing better or worse during the course. We've heard about the data, and the data that Larissa presented was actually fitting 100% to our data. So this is data on kidney survival. I want to quickly explain what this figure shows. So this is the number of patients with a surviving kidney function. So not patients surviving, but how many patients have kidneys that are still functioning and that do not need dialysis. And fitting exactly to what was mentioned, we have about 50% of patients who do not need kidney replacement therapy at the age of 20. And really, whenever I give this talk, and especially whenever I give this talk to colleagues in adult nephrology, they are really surprised that kidney survival is really so good, and it's much better than what also I was taught in med school and early during my career. So for us, a question would be, can we identify patients at high risk for rapid progression? Because I guess we all believe that these would be patients that could benefit most from early treatment or early intervention. So what we did a couple of years ago, and I'm not going to show all the details of this study, this has been published a while ago, is that we looked at antenatal and perinatal risk markers of patients that required dialysis either in the first year of life or in the first 3 years of life. And what you can see from also this slide is that this is only possible if many people work together. So I think we have 50 co-authors on this manuscript. And what we could find is that the volume of amniotic fluid, as it was pointed out previously, that the presence of kidney cysts and that the presence of enlarged kidneys are markers of early dialysis dependency. So the antenatal detection of these 3 markers are markers of early dialysis dependency in ARPKD. More recently, we looked at the genetics behind this. So this is a complicated slide, but I will try to guide you through this. This is we are looking at the variants in the PKHD1 gene, so the gene that is causing ARPKD, and we are looking at data from the ARPKD registry of 304 patients that had clinically diagnosed ARPKD and the detection of at least one PKHD1 variant. And let's start with this figure on the left-hand side. So here, again, we are looking at the time without kidney replacement therapy, so either dialysis or transplantation. So if the line was really flat, then none of the kids would have required kidney replacement therapy. The steeper the curve, the worse the course of the patients. And what we are comparing here is the different types of variants in this specific gene. So null means that both the copy from mom and the copy from dad are completely losing function, because you can have various different types of variants in the specific genes. And these are severe variants. And what we also see is that this is a group of patients that develops very early severe kidney disease. They require kidney replacement therapy very early in life compared to all other patients. We also looked at this for the liver disease, and this is what's shown in E and F here in the middle and on the right-hand side. I'm not going to go through all the details. I think it doesn't matter at this point. But what you can see is that the patients with these severe variants also show more progression of liver disease. This is what Larissa has said, that there are these patients that show both a severe affection of kidney and liver disease, and that we have been struggling for a long time to identify why this is and why some do show more kidney disease and some do show more liver disease, and some have rapid progression in both. So with this figure, we can at least identify one factor that is contributing to and identify patients that have a high risk for both severe kidney and liver disease. We then took this a bit further and looked at the specific site of the variants within the gene. And again, I'm not going to go through the details because I think it is getting a bit too far. But what we see is that if this is the whole of the protein fibrocystin that Larissa talked about, then we see that it is important where exactly the variants are. We looked at 4 different subsections of these proteins shown here in the different colors. And as you can see, variants that are especially in this part, they show more liver affection, and variants that are, for example, in this part, show very good kidney causes. Though here we are sort of starting to understand a bit more about the different types of variants and how they contribute to progression of the both kidney and liver disease. And this is a publication that has just come out. Another question that I get asked a lot is, in ARPKD, can we use peritoneal dialysis? Because people are worried that the kidneys are so huge that peritoneal dialysis would not work. And PD is obviously the mode of dialysis that as pediatricians, especially for young kids, we prefer to use. And what we did here is we compared the course of patients with ARPKD to the dialysis course of patients with other early onset chronic kidney diseases, so other congenital anomalies of the kidney and the urinary tract, or patients with congenital nephrotic syndrome. And again, it's the same time of figure that, the same time of figure that we've seen before. So, and you see that peritoneal dialysis, if this line is flat, then it works throughout the time equally. And you see that some of these patients develop problems with the technique of peritoneal dialysis over the time, but there is no difference between these 3 subgroups. So that was a cohort of young children, not newborns. This is something to be kept in mind. These had an age of roughly 2 years. But in these young children, PD works equally well in ARPKD and CACUD and CNS. And no one would doubt about using PD in CNS or CACUD patients. And then for the adults, we recently looked at it, and it's going to be very, very interesting to hear about the adults in renal radar. So we back then had about 40 patients, 40 adult patients in the registry, young adults in their early 20s. And what we looked at is the different courses. And again, what you can see here is that the different colors on the right-hand side, so each of these lines is an individual patient. And the different colors are sort of showing whether he or she had chronic kidney disease, whether he or she was on peritoneal dialysis, hemodialysis, or had undergone transplantation. And what it shows is just the variability that you've heard about previously. There are these patients that, do well into adulthood. And there are other patients that require, 3 transplants or even 4 transplants. So there is still a lot of variability. Genetics may be one aspect contributing to it. There may be other aspects that we are trying to trying to understand. So, is there anything from ADPKD that we could learn from ARPKD? So ADPKD is a much more common disorder, as you've heard, and there's a really very active research field in ADPKD. So is there anything that we could use that would help us for our rare ARPKD field? We've talked about the spectrum of disease, that there may be overlap between these two, and that there may also be overlap in the signaling events in the kidney cells that may be comparable between these two. For ADPKD, there are various trials going on, and we're going to look at tolvaptan in a bit more detail in a second. There are other trials that are going on for ADPKD. There have also been trials that did not come to a promising result, but it's still important to learn about these trials. So this was a landmark study by Vicente Torres and colleagues from the Mayo Clinic for ADPKD. They treated patients either with a drug called tolvaptan or with a control placebo, and what they could show is that kidneys were growing faster in the placebo group than compared to the tolvaptan group, and kidney function or loss of kidney function was quicker in the placebo group than in the tolvaptan group. So could this be something for early and severe ARPKD? Indeed, there are there's good evidence from preclinical models, from basic science studies, that there's overlap in the signaling cascades, as I have said. And so recently, the company Otsuka decided that there will now be 2 clinical trials to study tolvaptan in ARPKD. So one study is going to be to study if tolvaptan can delay dialysis in infants and children who are at enrollment 28 days to less than 12 weeks with ARPKD, and what they are going to look at is especially or is exactly the group of patients that will show the high risk patterns that we have described in the Journal of Pediatrics manuscript. So the patients with low volume of amniotic fluids and antenatal detection of cysts and large kidneys. And there will be a second study to see if tolvaptan is safe in infants and children. And this is more a safety study throughout childhood and adolescence. And really, I think this is a really good sign that there's now something moving in this field, and that there's some development of a first clinical trial in ARPKD. So what's the experience with tolvaptan in pediatrics? People are always worried, with tolvaptan, with the adults in ADPKD, they pass a lot of urine, up to 6 liters a day and so on. But, with the tolvaptan trials that are going to be launched, we're talking about children that are heavily affected. So that they, this is especially this high risk group that could have the greatest benefit of treatment. And surely within this trial, there will be plenty of visits at the hospital, but most likely these are kids that would be seen frequently at hospitals anyway. And the experience, so there was this important report by Rodney Gilbert from the UK who treated a patient with a severe form of ADPKD that looked like ARPKD, and he treated the patient with tolvaptan very early in life, and it worked out pretty well under close monitoring, or very well. And then there are other groups of patients in childhood especially from cardiology, that are treated with tolvaptan very early in life. So there is some experience with this drug, even in very young children. And I think it's so I'm really excited about seeing this development in the ARPKD field and some first approach of a targeted therapy for ARPKD patients. How do we go on from this? So this is a German initiative. This is called the NeoCyst Consortium, where a lot of or various of the major centers in Germany work together on early onset cystic kidney diseases. And as it was described for the UK, we are also trying to bring together biosamples and look at the causes of different types of cystic kidney diseases, not just ARPKD, but also nephronophthisis and Bardet-Biedl syndrome, etc., to also try to understand how how the spectrum of ciliopathies develops and why there is some overlap between the different diseases, and just to get a better understanding for these rare diseases. One thing is that we're trying to do a translational research, so what you can do, and for us as pediatricians, it's a nice thing to do because it's not painful. You can get cells out of the urine of patients, and then you can actually take them to the lab and grow them in little plastic flasks, and then try to understand a bit more about the signaling cascades that are affected in these different types of diseases. ERGNet or NeoCyst is a German initiative. Now, there's this European initiative called ERGNet that deals with general rare kidney diseases, where now many centers are teaming up. Unfortunately, we've lost some of the UK centers due to the recent political decisions. But on the continent, we're trying to get connected, and this is not just pediatric. This is also for adult centers, where we also try to collect patient data from many kidney patients with rare kidney diseases to also raise more awareness for these rare disorders, because many of the doctors just don't know enough about rare kidney diseases. So to briefly summarize, it is an inherited disorder that is mainly caused by variants in the PKHD1 gene, and I've tried to show you some of the data that may be helpful to understand why some patients develop more of a kidney phenotype and some patients develop more of a liver disease. It is a rare disorder, and we absolutely need to do teamwork on with these international networks. And there's a lot of work that has been done for ADPKD already, and I think we can really learn something from it for ARPKD. And with that, I've come to an end. I want to thank everyone who did most of the work. So Catherine Burgmeier really does a tremendous job with the registry, Claudia in the lab, all the funding agencies, and the support by PKD International and the German PKD Foundation, the ERNs, etc. And I'll be happy to take questions. And I'm really looking forward to next Tuesday, obviously, for those who are interested in football. And let's see whether this is rather going to end up in a this is Gareth Southgate. I just want to mention that it's him. I took him to the picture. Whether it's going to end up in one of these penalty things again, or whether it's going to end up in this in a situation like this match in Munich in 2001 that apparently happened, although I don't quite remember what happened on that day.
Fantastic, Max. That's a good way of remembering a good football game. Thank you very much. It was a fantastic talk. I'm just looking at the Q&As, and while people are again, sifting through some of the information, I might just sort of start off by asking. I guess one of the it's really helpful to have that sort of international collaboration, should I say, to get so many children and adults, as you point out, so 50% of them being in the sort of over 18 nearly, and their data together to then be able to make some firm sort of, what our understanding is. And it's, I think one of the big points I wrote down here for me was that kidney survival is good. And there are some good ways of marking that out. I think one of the things from a clinical field we find is that this is a very unusual condition when you see the child on your own, and what is sort of sometimes difficult to describe is that coming to a diagnosis takes time, and you don't get a genetic result back straight away. And if you don't know this condition and you're not looking out for it, it can take some time before you, if you like, press the button to go and get these investigations. And this makes clinicians and medical teams uneasy because they're not quite sure what they're dealing with. We heard about the story about the blood pressure, and sometimes those sort of things come up, and overall it it adds to the uncertainties and concerns for the families. So I just wondered, Max, it might be a slightly difficult question to answer, but I think you hinted towards that with your, the paper which highlighted some of the clinical markers which flag up, likely difficult course prenatally. Um, with reduced volume, big kidney size. Would there be anything you would potentially then point out during the early infancy, childhood, whilst teams are waiting for genetic diagnosis? And we flagged up helpline numbers where expertise is available. I just wondered whether you would draw on the registry experience to sort of help both clinicians and families who are on the call. Thanks.
So in our experience for families, it is very, very important to be connected and to hear from other families how they managed. And we obviously sometimes it can be a bit challenging due to data protection, etc. So we try to link the families with the German PKD Foundation, or we sometimes may just ask families, who have a kid with a disease, whether they may be approached by a family with a new diagnosis or things like that. So we try to connect these families. We've also set up something that is more general for children with early onset kidney disease, where they have one of these baby groups, where there may be children with CACUD and ARPKD, etc. But it's good to be amongst themselves and to to discuss the daily issues that we as doctors sometimes don't even know about. Now for us as doctors, we've learned some things from the registry. At this point, we're still also describing a lot of things. One thing that we've learned from the registry, I didn't include it in this talk, but we've become a bit more reluctant to do nephrectomies because we've seen the problems that Teresa mentioned about the hypotension afterwards, and the big changes between hyper and hypotension, and how difficult it is to manage this. And obviously there are these situations when the kidneys are failing and are not doing their work, and it may be a question, can this kid survive without taking out the kidney? But whenever possible, we've become sort of reluctant to take out the kidneys, because we've seen some also bad consequences of these hypertension episodes on the long run, also from a neurological and developmental point of view. So when possible, we try to avoid it. And then we've talked about the salt already. This is also something that you sort of can repetitively mention. We've talked about blood pressure, trying to bring it together. Blood pressure in the registry is a really difficult topic, because there are so many confounders in it, with all the different blood pressure medication that is being used, etc. So it's really a bit of a challenge to get reliable data on it. We are working on it, but it just will take a bit more time. And I think these are the main things that, and obviously we've learned the risk markers now. So as always in medicine, it will not tell you a clear prediction for this individual patient that is sitting right in front of you. It can only give us broad ideas for groups of patients. But as first treatment approaches are now coming up, it would help me to guide me a bit, which families I would approach, and for which families I would, offer to or ask them to maybe be included in such a clinical trial.